Should I start?
Just a second, sir. Good evening, everyone. This is Batul from IGCP, the moderator for today's session, and I would like to welcome everyone wholeheartedly at our platform for the better exchange of knowledge that is going to be shared by our stalwart who is present here with us today. Well, he is none other than the very renowned diabetologist, Dr. Brij Mohan, sir. Sir is MD in Medicine, FICP, FIACM, Fellow Diabetes India, consultant at the Department of Internal Medicine and Diabetologist at BMC Hospital, Kanpur. So with Sir's wonderful insights, we are going to talk about the topic for today, which is management of gestational diabetes in 2024. Before moving on to the session for today, let us have a brief look on what the topic says about. So the management of gestational diabetes in 2024 embraces a comprehensive approach emphasizing personalized care and proactive interventions, tailored diet plans, regular exercise, and glucose monitoring are central to maintaining stable blood sugar levels during pregnancy. The close collaboration between healthcare providers and support network ensures optimal maternal and fetal outcomes, reflecting advancements in gestational diabetes management in the modern era. So in this session, we'll be learning about this particular topic. So now without any further delay, I would like to welcome Sir at our forum and would like to hand over the session to him for his precious talk to begin. So over to you.
Good evening, all the attendees for this session on management of gestational diabetes in 2024. And at the outset, I'd like to thank IJCP for opportunity. So let us start with the topic of gestational diabetes. Whenever we see a pregnant female with diabetes, it can be pre-existing diabetes or gestational diabetes. Pre-existing diabetes can be type 1 diabetes, which is not uncommon these days, and type 2 pre-existing diabetes in a pregnant female is quite common these days. And there can be gestational diabetes also. This gestational diabetes can be pre-existing undiagnosed diabetes, or it can be through gestational diabetes. So once we diagnose diabetes for the first time during pregnancy, this is how we define gestational diabetes. It is glucose intolerance of any severity with onset or first recognition during pregnancy. So that includes pre-existing but undiagnosed diabetes, and that can be differentiated by HbA1c if it is more than 6.5. Remember, if HbA1c is more than 6.5, that means it is a pre-existing undiagnosed diabetes, or if it is less than 6.5, it can be true GDM. If we look at the epidemiology of diabetes in pregnancy, GDM particularly is very common in India. There are various studies which say it can be between 10 to 14.3%, which is much, much higher than the Western population. More common in urban areas, in females who are comparatively older. The age which cut off is 25 years, and that is very, very pertinent in today's scenario where girls like to study, marry, and then maybe another 3-4 years they have pregnancy. Or it can be obese females in which GDM is more common. It is characterized by increased risk of large for gestational age birth weight that we know for years together. And there can be neonatal and pregnancy complications, both for mother and for fetus or newborn also. We'll come to that. It doubles the risk of serious injury at birth, triple likelihood of cesarean delivery, quadruple incidence of neonatal intensive care unit admission. So this is very, very important to recognize that this female, pregnant female, is suffering from diabetes. There is association between maternal glucose tolerance test results. These are continuous and with no clear inflection point. That simply means that this intolerance of glucose during pregnancy, it starts well within the normal range. Increased risk of long-term maternal type 2 diabetes is there. Those females who had GDM are more likely to have maternal type 2 diabetes, and there is possibility of abnormal glucose metabolism of offspring during childhood. These are various risk factors for GDM. As you can see, the age limit given here is 25 only, which is very pertinent in today's scenario. BMI, if it is more than 25, or metabolic syndrome, first degree relative are suffering from diabetes, previous GDM or glucose intolerance, previous macrosomic baby, PCOS, previous polyhydramnios, and previous unexplained perinatal loss or birth of malformed infant. These all females are at high risk of GDM. In Indian patients, universal testing is important and is a must because Indian women have 11-fold increased risk of developing glucose intolerance during pregnancy as compared to Western counterparts. All women should be screened for gestational diabetes at first opportunity, that is the first visit, even if there are no symptoms. Majority of females during pregnancy do not have any symptoms, and when we test, they turn out to be GDM. So what the screening, when should the screening be done? First screening, ideally at 12 to 16 weeks or at the time of first antenatal checkup. Second screening at 24 to 28 if the first screening is negative. Third screening at 32 to 34 weeks. So if first and second are negative, we go for third screening also. Now, what is the criteria for diagnosis of GDM? There is international guidelines and international validation is there for these guidelines. The test should be performed at 24 to 28 weeks of gestation. 70 gram, 2 hours oral glucose tolerance test is used. If FPG, that is fasting plasma glucose, is more than 26 or equal to 126, overt diabetes is diagnosed. That means the person or the female is suffering from diabetes per se. If it is less than 126, GDM is diagnosed, gestational diabetes is diagnosed if any one or more of the following values exceed the threshold shown below. That means the fasting equal to or more than 92, 1 hour more than 180 or equal to 180, and 2 hour equal to or more than 153. So any of the three, if it is there, we label the female to be suffering from gestational diabetes mellitus. Then there is an Indian criteria also that is given by DIPSI. The DIPSI stands for Study of Diabetes in Pregnancy Study Group. This is Indian criteria. What the diagnostic procedure is, it is a single test procedure as opposed to oral glucose tolerance test in IA-DPSA. Fasting or non-fasting state, irrespective of last meal timing, while in IA-DPSA criteria, it is fasting state, single blood sugar with 75 gram oral glucose in 300 ml of water, and GDM is diagnosed if the 2-hour plasma glucose is more than 140 milligram per deciliter. So this is DIPSI criteria. DIPSI diagnostic protocol, if you look at it, pregnant female walks into your clinic testing for GDM at first antenatal visit, 75 gram of glucose, irrespective of meal, 2-hour plasma glucose value is taken. If it is more than 140, this is GDM. If it is negative, go for second screening or maybe third screening. The second screening, as I told, is at 24 to 28 weeks, or it may be 34 weeks also. Now, there is a term like early gestational diabetes, which we see very commonly in Indian females. Early GDM, eGDM, diagnosed during early pregnancy, that is defined as less than 20 weeks. It is more severe form of GDM. The prevalence is ranging from 0.7 to 36.8. Wide range prevalence is due to difference in the diagnostic criteria, and there are similar risk factors as with GDM. The impact of early GDM is macrosomia is more common, cesarean delivery, induction of labor is more common, hypertension, preterm delivery, and shoulder dystocia because of large for date fetus is more common. Insulin need is higher. There is possibility of higher incidence of type 2 diabetes in females diagnosed with early GDM. What are the effects of gestational diabetes? There can be effect in the mother, preeclampsia, polyhydramnios can be there, operative delivery is more common. As I told you, perineal trauma is more common and risk of future diabetes is there, while fetal or neonatal implications are the possibility of macrosomia, that is large for date fetus is there. So there is higher possibility of birth trauma, prematurity can be there, neonatal metabolic complications like hypoglycemia, hyperbilirubinemia, hypocalcemia, and polycythemia is there. And there is a risk of future obesity and risk of future diabetes in these kids born to GDM mothers. Now, coming to glycemic goals in pregnancy, we know how to diagnose and what are the effects of gestational diabetes on fetus, on mother. Once we come to management, we need to know what are the goals of blood sugar in pregnancy. What should be done? Fasting, preprandial and postprandial blood glucose monitoring is recommended. These values are 70 to 95 for fasting plasma glucose. 1 hour postprandial should be 100 to 140 and 110 to 140, and 2 hours plasma postprandial glucose should be 100 to 120. So we must try to maintain blood sugar below 95 of fasting and 1 hour below 140 and 2 hour below 120. A1C is lower during pregnancy because of increased RBC turnover, and that is seen even in non-diabetic population also. In pregnancy, there is increased RBC turnover, and we know that HbA1c is dependent upon RBC lifespan. A1C target during pregnancy is less than 6 if this can be achieved without hypoglycemia, but it may be relaxed to less than 7 if necessary to prevent hypoglycemia, which must be prevented, and the level of evidence is B. B means we do not have randomized double-blind control studies, but there is enough evidence as of now. When used in addition to preprandial and postprandial glucose monitoring, CGMS, continuous glucose monitoring, can help to achieve HbA1c target in diabetes in pregnancy. But remember, it is important to keep glucometer in check pre and postprandial glucose other than CGMS. Even if CGMS or continuous glucose monitoring is being done, it should be substantiated by blood glucose reading during meals. Preprandial and postprandial glucose monitoring should be done by glucometer. Coming to management of gestational diabetes, lifestyle or behavior changes that includes medical nutrition therapy plus exercise plus weight management is essential component of management of GDM, and majority of females may need only this much lifestyle or behavior changes. Insulin is the preferred first-line medication, and that should be added if drugs are needed to achieve glucose glycemic targets, and level of evidence for this is A. That means there is double-blind, multi-center, randomized control trial to substantiate that insulin is the drug of choice, is the first-line medication in GDM. Metformin and glibenclamide should not be used as first-line agent, as both cross placenta to fetus. This is again, the evidence is A. And many of you who are attending this webinar they are aware that metformin is there in Indian guidelines. Glibenclamide causes hypoglycemia. It should not be used. Other oral or non-insulin injectable medications lack long-term safety data. Metformin, when used to treat PCOS, that is polycystic ovarian syndrome, and induce ovulation, should be discontinued by end of first trimester. There is no evidence to show that this is useful beyond first trimester. The previous concept was that it should be continued throughout pregnancy, while the level of evidence for this recommendation is again a substantial evidence as of now. Meta-analysis of 11 randomized controlled trials demonstrate that metformin does not reduce the risk of GDM in high-risk individuals or females with obesity, PCOS, or pre-existing insulin resistance. And it is important to put those females with pregnancy on telehealth visit in view of improving outcome in GDM compared with standard in-person care. And the level of evidence is A. Now coming to monitoring of diabetes in pregnancy, this is again very important. Frequent monitoring of glycemic control and prompt changes in management are essential to ensure good outcome. The options for monitoring are self-monitoring of blood glucose, and this is important that all insulin-treated patients 4 to 7 times per day of self-monitoring of blood glucose must be done. Minimum 4 times and maximum 7 times. It can be HbA1c, serum fructosamine, or glycated albumin for short-term glycemic control. Continuous glucose monitoring that I have already mentioned, and measurement of fetal abdominal circumference and weight by ultrasound must be done by a qualified, trained pregnancy ultrasonologist. We must start with lifestyle and behavior management for GDM. After diagnosis, treatment starts with medical nutrition therapy, plus physical activity, plus weight management depending upon pre-gestational weight. Glucose monitoring again is very, very important. Depending upon population, there are studies suggesting that 70 to 85% of people diagnosed with GDM can be managed with only and only lifestyle modification. That means that most, if not all, of patients can be managed by lifestyle modification. Physical activity, there is a systemic review demonstrating that improvement in glucose control, there is reduction in need to start insulin or reduce insulin dosage with exercise. Heterogeneity in types of effective exercise. It can be aerobic, resistance, or both. Duration of exercise varies from 20 to 50 minutes per day. 2 to 7 days a week of moderate intensity exercise is recommended. One should take an opinion of obstetrician before giving exercise prescription. This is again very important, that not consulting an obstetrician who is going to deliver at the time of full term is going to be disastrous. Coming to medical nutrition therapy, what are the aims? Cornerstone of GDM management. It must fulfill minimal recommendation of nutritional recommendation for pregnancy, achieve glycemic goals without loss or undue weight loss or undue weight gain, avoid ketonemia or ketonuria from calorie restriction. This is again very important. Starvation. Obese or overweight females can be advised moderate carbohydrate and calorie restriction. Meal plan should be tailor-made for individual, easy to understand, easy to follow, and it should be in accordance with that given patient. Small frequent meal once in every 2 to 3 hours. Avoid prolonged fasting to avoid hypoglycemia. Bedtime snack is important. It is advisable to prevent development of ketosis at night. Ensure adequate hydration of pregnant female. Artificial sweeteners are associated with preterm labor. They should be avoided during pregnancy. Again, very important. And physical activity and stress management should be advised. Physical activity should be in accordance with obstetrician's plan. MNT for GDM is individualized nutritional plan developed between pregnant female and trained registered dietitian who is familiar with GDM management. Food must provide adequate calorie intake to promote fetal or neonatal maternal health, achieve good glycemic control, and promote optimum weight gain. Now, this is important that what is optimum weight gain? The weight gain is maximum allowed is 9 kgs during 9 months of pregnancy. This is the optimum weight gain. It may go up to 12 kgs, but in majority of patients, it is in females, it is up to 9 kgs. Recommended dietary intake is minimum of 175 gram of carbohydrate or 35% of 2000 calorie diet, 75 gram of protein and 28 gram of fiber. Fiber is very important and that should be supplemented. Amount and type of carbohydrate impact glucose level. Simple carbohydrate will result in higher PPG values. Complex nutrient dense carbohydrate result in controlled fasting plasma glucose, postprandial plasma glucose, lower free fatty acids, and improved insulin action. There are vascular benefits and it reduces excess of infant adiposity. The large for date fetus is not there. MUFA, monounsaturated fatty acid and polyunsaturated fatty acid should be given. Saturated fat should be reduced. Avoid trans fat. Individual who substitute fat for carbohydrate may enhance lipolysis and promote elevated fatty acids which may worsen maternal insulin resistance. Fasting urine ketone testing may be useful to identify those who are severely restricting carbohydrate to control blood glucose level. This is very common in females who are pregnant females who are using insulin to reduce their calories intake and they test positive for urine ketone. Coming to pharmacological therapy, once lifestyle and insulin has been demonstrated to improve perinatal outcome of in two large randomized controlled studies. The individual RCTs support limited efficacy of metformin or glibenclamide to reduce glucose levels for treatment of GDM. These agents are not recommended as first-line treatment for GDM because they do cross placenta, and data on long-term safety for offspring is of concern. In separate randomized controlled trials, glyburide and metformin failed to provide adequate glycemic outcome in 23 to 25% of GDM. Metformin is recommended by national guidelines in diagnosis and treatment of GDM, that is Ministry of Health, Government of India guidelines. Metformin, when to use, when not to use. Metformin is associated with lower risk of neonatal hypoglycemia, less maternal weight gain than insulin in systemic use. Metformin readily crosses placenta and resulting in umbilical cord levels as high or maybe even higher than simultaneous maternal levels. There was a study, metformin in gestational diabetes, the offspring follow-up study analyzed, which showed that 7 to 9-year-old offspring exposed to metformin were heavier and higher waist to hip height ratio and waist circumference than those who were put on insulin for GDM. The difference was not found in Adelaide cohort, while it was there in Auckland cohort. There are two randomized controlled trials for metformin for PCOS. Follow-up for 4 years old offspring demonstrated that higher BMI is possible in offspring and increased obesity in offspring exposed to metformin. Follow-up study at 5 to 10 years showed that offspring had higher BMI, weight to height ratio, waist circumference, and there is increased fat mass, which is borderline. Recent meta-analysis showed that metformin exposure resulted in smaller neonates with acceleration of postnatal growth, resulting in higher BMI in childhood. There is no need to continue metformin in PCOS. When to use? People with GDM requiring pharmacological therapy who may not be able to use insulin safely or effectively during pregnancy due to cost, language barriers, comprehension, and cultural influences. You must make a note on your prescription that metformin is being prescribed because the patient is not accepting insulin at all. Oral agents may be alternative for those individuals after discussing known risk. It should not be used in pregnant female with hypertension, preeclampsia, or risk of IUGR, intrauterine growth retardation, due to risk of growth restriction with metformin. Glibenclamide crosses placenta, should not be used. Coming to insulin use during pregnancy, it is to be individualized. No convincing evidence for superiority of one insulin regimen over another in randomized controlled trial. Postprandial glucose values need special attention in pregnant diabetic females. Many females with GDM have elevation of single post-meal glucose level. In such case, a single dose of regular or a rapid-acting analog insulin before meal will do the job. Around 16 weeks, insulin resistance begins to increase. In total daily dose increases around 5% per week to 36 weeks. This results in doubling of daily dose compared to early pregnancy. Start with 0.5 to 0.7 unit per kg per day, usually increase to 0.8 kgs in second trimester, 0.9 kgs in third trimester, in 1 unit per kg a term. Individualization is based on carbohydrate content of diet. Fasting is high, maybe that you put the patient or pregnant female on NPH or basal insulin at bedtime. If after lunch or after dinner glucose levels are high, regular insulin may be needed. Basal bolus therapy or premix insulin may be needed to achieve optimal glucose control. So, a pregnant female with GDM, give a trial of 2 weeks for medical nutrition therapy plus exercise. If 2 hours PPG is less than 120, monitor 2-hour PPG. No need to go for insulin. If more than 120, then you need to go for insulin, and monitoring should be 4 to 7 times per day. These are the insulin injection site from front and back. This is usually used. Pregnant females with GDM on insulin start with rapid acting insulin with or before meal. It can be human insulin R, Aspart, Lispro, blue lysine or Fiasp insulin. Adjust the dose to target. Target is less than 120 of 2-hour per ppg. If fasting is more than 95, start with basal or premix insulin. It can be NPH, Betimir, Tresiba, Glargine, insulin 3070 of premix insulin or Rhizodec. Here, I must mention that Glargine is not approved yet, but it is being commonly used in pregnant females. Although the evidences suggest, if there are enough evidences to suggest that aggressive management of GDM improves outcome for mother as well as for next generation. That simply means that if you control blood sugar during pregnancy, the next generation will not be obese. The pregnant female will not turn out to be type 2 diabetes in near future. With that, thank you very much. If there are any questions, I'll be very happy to answer.
Thank you so much, sir. Thank you for such an overwhelming talk that you have shared on our platform, and for making our viewers understand about it in such a great manner. Thank you so much for that. We have received 2 questions from the participants, sir. With all your due permission, I would like to put across those questions to you.
Yes, sir.
So the first question is related to the key goals in managing gestational diabetes and how do they differ from managing diabetes outside of pregnancy?
It's altogether different. I told you the goals are less than 95 of fasting, less than 120 of postprandial 2 hours blood sugar. While it is not so in non-pregnant adults, in females who are not pregnant, the values may be 90 to 130 or 80 to 130 of fasting, and postprandial of less than 180. So it is very tight in pregnant females. The goals are entirely different.
Thank you so much, sir. Thank you for answering that question. We'll move to the next question that we have received. And the next question is related to Potential maternal and fetal complications. So what are the potential maternal and fetal complications associated with gestational diabetes? And how do you mitigate these risks through management?
I told you the complications can be for the mother. In the mother's complication, the biggest complication is if there is gestational diabetes, the possibility of type 2 diabetes in future is very, very high as compared to those females who do not have GDM during pregnancy. One very important difference is the higher possibility of type 2 diabetes in females who have GDM. While in fetus, it is large for date, birth injury, the possibility of obesity, the possibility of type 2 diabetes, and even heart disease during early childhood, 9 to 5 years, I told you. The possibility of obesity is very high in females who are born to in the just hold on. In those who are born to pregnant females, the possibility of obesity goes up, the possibility of diabetes goes up, and those who are treated with metformin or glibenclamide, the possibility of obesity is higher. So that is why now they say that it is safe to use only and only insulin during GDM. Sorry, there is a background noise because of this Ram Navami Julus going on.
Right, sir. No issues, sir. No, not a problem. We'll move to the next question and the last question before we conclude. So the question is related to discussion of recent advancement or research findings. So can you discuss any recent advancement or research finding in the field of gestational diabetes management that have influenced your clinical practice?
Yes, I told you. When we were student, we were told that all PCOS females who have conceived on metformin should be continued on metformin to avoid possibility of gestational diabetes and type 2 diabetes. While it is not so, there are studies that those females who have taken metformin, they have higher possibility of fetus, which is small for date, but more of weight gain during early childhood, more possibility of obesity, more possibility of type 2 diabetes in childhood, and more possibility of even CAD.
Thank you so much, sir. Thank you for answering that question and all the other questions for our viewers and making them understand the topic in such a better manner. I would like to thank all of our viewers for their ardent participation that they have shown by staying tuned with us throughout the session and putting across such interesting questions to us. So thank you to all of them. And thank you so much, sir. With this, we would like to conclude the session here for today. Until next time.
Bye.
Thank you, sir. Bye-bye.
Good night. Good night.